Para el CACI es un honor contar hoy con esta actividad oficiada por Medtronic. Les agradecemos mucho. Medtronic nos está dando un gran soporte al colegio, no solamente a través de ser un sponsor de categoría platino, de ser fundador del centro de simulación. Esta actividad, incluso el simposio del mediodía durante el simposio del CACI. Bueno, tenemos el gusto de recibir al doctor Hemal Gada. El doctor Hemal Gada es el director del programa de intervenciones estructurales en el Pinnacle Health System en Harrisburg, en Pensilvania, en los Estados Unidos. Bueno, todos los que estamos acá sabemos las contribuciones que el doctor Gada ha hecho en cuanto a la técnica de TAVI basada en la alineación de cúspides y los beneficios que esa técnica puede tener para los pacientes, disminuir la tasa de marcapasos y acelerar los tiempos de inflamación. Así que, Dr. Gada, welcome. It's a pleasure to have you here. And thank you for coming to CACI. So it's ready for your presentation.
Thank you. Thank you all for having me here today. We've had a couple of really great days of cases with Dr. Mendes and Dr. Steckman today. And we were doing this technique, which they've mastered, and they can tell you all about it too, but I'll talk about why it's necessary. Why it's necessary is because this valve is linked to a very high rate of permanent pacemaker implantation. From its inception in clinical trials, it's had reported pacemaker rates above 25%. And that is not a viable solution as we get into a lower risk population. So I really was raised on SAPIEN devices. I did my general cardiology fellowship at Cleveland Clinic and my interventional and structural training in Columbia, New York City. And these are big partner sites. And so when I was doing my interventional and structural training, all I did was deploy SAPIENs all day long. And I was taught to like that device quite a bit. But as time went on, I did find a reason to use this device. And I found a technique that helped me get the outcomes that I wanted with this device. So I hope to kind of share with you my story as to how I was able to embrace this particular system. And as we roll out into lower risk populations, I do believe that this is the better device for our patients. So as far as conduction disturbances are concerned, we have different risk factors, clinical, anatomic, procedure, and operator related. The clinical risk factors are people that are elderly, if they have right bundle branch blocks coming in. And both cases that I did with Dr. Mendes and Dr. Steckman today, we each had cases where we had right bundles coming in. And if you look at published literature, pacemaker rate with right bundle branch block varies between 25 and 70% with regards to transcatheter valve replacement. Other pre-existing conduction disturbances, what would worsen someone's chance of needing a permanent pacemaker with a right bundle? A concomitant left anterior fascicular block, add a first degree AV block on top of that. And then you've got someone who's at really high risk, bad phenotype, that could potentially need a permanent pacemaker. There are anatomic issues to consider as far as predictors. Membranous septum length was a topic of a recent article that was published by authors at NYU. It's a very interesting concept. The technical application of membranous septum length and how we use that in the procedure is questionable at this time, but it's definitely something that bears consideration, and I'll tell you about the membranous septum in just a moment. The thickness of the non-coronary cusp, elevated left coronary cusp calcium, also very important anatomic predictors of permanent pacemakers after transcatheter aortic valve replacement. The thing that I'm going to spend the most amount of time talking about in this particular presentation is this right here, which is implant depth. Implant depth is we were taught historically to understand it, and what I think is a better way of understanding implant depth. So in order to understand implant depth and why it matters and this whole thing about the membranous septum, we have to understand very basic anatomy. And the basic anatomy is as follows. We have three cusps of the aortic valve. Each insert in at different depths in relation to the left ventricular outflow tract. There is this structure called the membranous septum between the right and non-coronary cusps in the visceral line, the plane between the right and left coronary cusps, the right and non-coronary cusps. Below that is this area called the membranous septum where the conduction system actually gets housed. It's protected in this area. But then below the membranous septum, the conduction system becomes very superficial in the area of the muscular septum. And so this area is crucial at kind of determining whether or not someone's going to get a permanent pacemaker after transcatheter aortic valve replacement or surgical AVR. And really the whole point here is if you injure things below the membranous septum, then you run a risk of needing a permanent pacemaker. So we know that deep implants then would increase the risk of needing a permanent pacemaker, but how do we gauge implant depth? Well, transesophageal echo is one way. We're all trying to move towards minimalist types of procedures, less people in the room, less technical expertise, less sedation on board, possibly getting away from general anesthesia, all of these things. Well, if we're going to do that, then transesophageal echo is probably something that we want to do without. The other thing about transesophageal echo is that it's also two-dimensional imaging. And when you're looking just at 2 dimensions, you're not seeing the third dimension. Unless you're doing 3-dimensional TE reconstruction, which if you're deploying a valve with live 3D TE, it's very difficult to look at that. The more common way of assessing implant depth is aortography. Aortography also is 2-dimensional imaging. And so it relies on the ability of contrast to fill the base of the native coronary cusps. And then there's this whole concept of parallax that enters into the picture. For those of you who don't know what parallax is, I'm going to demonstrate that. But the point is that if you're staring at something that you believe to be in plane, okay, and then you put a valve in that, and then you rotate something to make the valve look like it's in plane, well, then you lose all reference to the thing that you just rotated out of. And that's a little bit of a vague description, but I'm going to describe it to you. So when we think of depth, we think of this annulus. And the annulus is a made-up structure. It doesn't exist in the human body. But it's our description of the hinge points of each of these leaflets. And then we draw a plane at the nadir of each of these leaflets. And so it takes 3 dots to draw a plane. That's what we have, 3 dots. And we assume that they're in some line. And what we're then trying to do is understand where a valve has deployed in relationship to this plane. And so here's just an example of how difficult it is to understand implant depth. This is us deploying a SAPIEN valve. This is the coplanar view that we were all taught. Non-right-left equidistant coplanar, the traditional coplanar view. On the right side of the screen is us deploying the SAPIEN valve. When we deploy the SAPIEN valve, I think we get a good result. But if you ask me what my implant depth was, I'm going to actually be very confused. Because the SAPIEN valve now has parallax in it. So it has a front side and a back side. And now I'm trying to understand what my depth of implantation was. Was it 2 millimeters? Was it 6, 8 millimeters? And in reference to what? Because all 3 of these cusps insert in at different depths. So what exactly am I saying depth? What exactly is that depth? And what is it in relation to? So this is the view, again, that we were all taught to deploy valves in. And when we look at the right side of the screen, we've rotated the gantry such that each of these hinge points is in some sort of coplanar view equidistant from one another. Okay. The problem with this view is when we really think about it, and we think about the conduction system, this view is not a good view to reference the conduction system. Why? Because the conduction system exists below the non-right commissure. It relies on your ability of separating the non-coronary cusp and the right coronary cusp and looking below that separation. And if you have things that are overlapped, you basically obscure or shorten that area. So you don't really know where the conduction system lies in this particular view. Meaning, if you look north of these points, the commissures are not there. There's no commissural plane. Whereas the view that we now deploy valves in is this particular view. So when we're deploying our Evolut platform, we go to this view. This view overlaps the right and left coronary cusps, leaves the non-cusp independent. This is our coplanar view, but it's a cusp overlap view. It creates a 2-dimensional representation of the annular plane. And in the middle here, you do have the non-right commissure, which is where the conduction system is. The other great thing about this view is when we actually cross with a wire and we put a stiff wire into the ventricle to then transition our delivery system through it, the wire will most always go to the non-right commissure. That's where the wire is going to sit. So it makes total sense that it will simplify the core valve procedure, as I'll show you, because again, we are now crossing the annular plane at some perpendicular angle where our wire is completely on fus. We're looking right at the wire. So this is just showing you on fluoro-CT how to obtain the view. It's very easy. We just go to the traditional coplanar view. We shift a little bit of RAO, we shift a little bit of caudal, and we basically are going to overlap these 2 points. The interesting thing about the annulus is that it will remain there on 2-dimensional imaging, but when you start rotating the gantry, certain points lose their representation related to the native annulus. So, if I was deploying a valve in LAO projection, okay? If I was deploying a valve, say LAO 30, caudal 15, because that's what we were taught how to deploy core valve. So if I was deploying an LAO 30, caudal 15, what I've done now is I've rotated out of my native annular plane. I've rotated around the left cusp. I've dropped the non-cusp, I've raised the right cusp, and now neither of these dots, and I would argue this dot isn't exactly representative of the annular plane. So if I have a pigtail at the base of the non-coronary cusp, and I'm deploying in this projection, I am liable to add somewhere between 2 to 5 millimeters to my depth of implant. And so if I'm taught to do this, and I'm in the US pivotal trial for a core valve, or in the CACI trial for core valve, or any other trial, Medtronic low risk, I'm risking a pacemaker. Because if I'm deploying in this view, and I think that I'm 3 millimeters deep, chances are I'm significantly deeper than that, especially as it relates to the conduction system. This just shows you, again, on fluoro-CT, what happens to that blue dot as we rotate the gantry, LAO 30, caudal 15. So our implantation technique is just 2 views. And I'm going to elaborate on this slide, but this is just kind of the take-home slide right here. This is the most important slide in the presentation. So really, we start out in a view that overlaps the right and left coronary cusps. It leaves the non-independent. That's most often an RAO or AP caudal view. That view, as I just discussed, will take parallax out of the ring of the delivery catheter of the evolute. Why does it do that? Because the wire is sitting in the non-right commissure. So as the delivery catheter crosses that plane, that marker band, all of a sudden it becomes a band. You know, it's not a ring. You take parallax out of it. For evolute, after flaring out and understanding depth related to the non-coronary cusp, we then rotate LAO to take parallax out of the valve, mainly to see what it looks like on the left side. And I'll show you kind of how we use that. So again, this view isolates the non-coronary cusp by overlapping the right and left, generally in an RAO imaging plane. As I discussed, it maintains basal plane alignment of the coronary cusps. It elongates the outflow tract and the membranous septum. It reduces or removes parallax in the marker band. And if you look at what's happening to the root angle of the aorta as we shift in the cusp overlap view, it becomes more shallow. So if you have an angulation of 70, 75 degrees on your typically assessed root, this will actually make it more shallow. So by going cusp overlap, you're going to, again, create a little bit more favorable, less horizontal of a view. It does rely on your ability to get a good quality coronary gated CT. And by good quality coronary gated CT, I'm not talking about 320 slices. 64 slices is fine, okay? Cranial caudal 16 centimeters. And you want that coronary gated CT to be able to guide you to predict where this annular plane is. Because when we do the CT reconstruction, and this is pre-Mencio, but if you do CT reconstruction on any program, it's absolutely critical to find the center of each cusp and go down right to its touch point. So you see us rotating around the annular plane here, going up to the mid-body of the leaflet, dropping back down and placing those dots very precisely at the insertion points of each of those leaflets. So we do that for all 3, and that's how we get our annular plane. This is something that we can basically double check, triple check, and for people that are interested that don't know how to do this, Medtronic with Juan Gaspar, has set up a very nice set of imaging specialists that will help you learn this. After we do this, we basically then shift to the cusp overlap view, keeping the green dot and the red dot completely over one another, with the non-dot isolated. In some anatomies, it may be quite difficult to achieve the cusp overlap. But if it's difficult, we cheat up the curve a little bit. So say in my lab, it's impossible for me to obtain anything steeper than caudal 35. And I've reconstructed this to be an REO 13 caudal 42 cusp overlap. You can then just migrate up the S-curve a little bit and get a better working view. Now, are you going to have a little bit of parallax in the marker band when you come across? You probably will, but that's okay. You don't need to be perfect, you know? This will just pretty much put you there, okay? And so that's kind of the art of it, all right? You have to be obviously very aware of your practical limitations with this type of view, but you can assess and modify the view accordingly. A lot of our ability to avoid pacemakers also goes with what we do procedurally in the room with this view. So after we cross the arch, we move to the predetermined cusp overlap view. We're obviously got a pigtail at the base of our non-coronary cusp, and we don't go any lower than mid-pigtail with this marker band. Why? Because there's plenty of stuff here that pins back the non-coronary leaflet. We don't have to plunge the valve into the LVOT, okay? That's another setup for a pacemaker. So if you take this entire capsule and shove it into the LVOT, that's not helping you with your valve deployment. The valve is naturally going to transition out of the delivery catheter down into the left ventricular outflow tract. So you really just need to keep the valve right about there. The ability of you to get parallax out of the marker band also depends on what type of wire you've chosen for the ventricle. You want that wire to sit at the apex of the non-right commissure. The stiffer the wire, the better. So I routinely use double curve Blunderquist in my procedures. If you use a Confida or Safari, that's a lighter wire. It may not go all the way to the apex of the non-right commissure, so you can, again, a little bit of parallax in the marker band, but it's okay. It's fine. We'll adjust for it. I would not worry about the ability of a double curve Blunderquist to cause any kind of ventricular trauma, because we've now done over 1,200 TAVRs with double curve Blunderquist, and we've not had a single issue with ventricular perforation. If you know how to handle the wire, it should not be an issue. Here's the initial descent. We're doing very slow turns here, and like I said, the valve is naturally going to migrate down towards the left ventricular outflow tract. Here, position 1's not doing much of anything. And if anything, there may be a little bit of gentle tension or push forward, but really what we're trying to do is focus on an area about 1 to 2 millimeters below the insertion point of the non-coronary cusp. Once we get to that point where we like where the valve is flaring out to, we get to the third marker band, now we rapid pace. And everyone asks me, why are you rapid pacing when you're doing this? Because I want to limit any kind of translational motion. And it's not like we don't have a pacemaker wire there. We're pacing over the left ventricular wire. Okay, so we have alligator clip in the field. And we create a current that way to basically rapid pace at a rate of 180 to get up to the point of no recapture. And I would argue anything that's greater than a rate of 120 is probably going to be good enough. I pick 180 because I want to smash the blood pressure. We just don't want it to be a factor. I don't want ECT to be, I don't want blood pressure. If someone has a really bad EF and they've got hypotension and you know that they're very fragile, don't rapid pace. It's okay. This valve offers you the freedom to do that. And really the whole point of this is to limit stroke volume. So if the patient's intrinsic stroke volume is really poor, you don't have to worry about the rapid pacing. And so this will allow you to complete the procedure quite efficiently and will allow for the valve to maintain stability once it's flared out and hit the base of the non-coronary cusp. After this, we take a quick shot in the view that we just had, and it shows that the valve is about 2 millimeters below the base of the pigtail, which is kind of in our target zone. Then we roll LAO. So why do we roll LAO? Yeah, I want to make sure that I caught the left coronary cusp, okay, which I did.
But sometimes the valve, and on the left side, it may be 2 or 3, hopefully, but it may be 5 or 6. It may be 8. And you need to think about what you want to do in that situation, right? Because you'll see the door of paravalvular leak right there when you do that aortogram in that LAO view. And so if you're landing at like 5 and you're 1 on the 9, well then what position 1 going to do with the catheter position here? They're going to push, okay? And the reason why they're going to push when they deploy the valve is you want to pivot off of here and you went higher up on the left, okay? The case today with Matthias where we were at 3 on the 9 and we were like 8 on the left. What did we do? We recaptured. We recaptured partially. We brought the non up to 0 or 1, and then we were fine on the left. And so the left view offers you the ability of tailoring your implant a little bit better so you don't have paravalvular leak on the left side. That's really the key about that particular point. Your full release is going to be slow and methodical. I do 15-degree turns. I free up the catheter system, 15 degrees more, free it up, 15 degrees more. This then controls your pace of actually releasing these tabs. The slower you go, the better. It allows for the valve to really sink in the annular plane. You'll get no vertical movement on tab release. And this is really how slow it is. The 5 cases that I've done with these gentlemen since I've been here, this is how we basically deploy the valve. I was positioned 2 on all 5 cases. This is how we deploy the valve. And so the wire's back, just sticking out of the delivery catheter barely. There's no tension in the system. The nose cone is center lined, and we're just rotating 15 degrees and letting the tension shake out. And so that's basically how we deploy the valve. Recapture considerations, I went over briefly already. At the point of no recapture, we're going to do the non-coronary cusp angiogram, the LAO angiogram. We're going to understand where we landed on the non, where we are relative to the left. If there's a big jet of paravalvular leak, do we have to then modify our implant? And I would say you want to be no deeper than half a pigtail underneath the annular plane. Okay, so no deeper than 5 millimeters on the one side. So I want to show you some examples and try to go over some of the concepts that I just talked about. So the implanter view on this particular patient is LAO22 cranial 4. This is our traditional coplanar view, non-right-left equidistant coplanar. On the right side there, you have RAO7, caudal 16. That's our cusp overlap. We've got non-coronary cusp isolated, right-left overlap. We're doing transesophageal echo on this patient for unrelated reasons. I tried to cap the patient radially. They were moving around like crazy. So I was just like, look, when we do your TAVR procedure, we're going to get general anesthesia on board. We're going to intubate you. But I did want to do a TE at the time because I wanted to prove something to myself. So this was the cusp overlap view. We're about 2 to 3 millimeters below the pigtail as we're flaring out. We're about to get to the third marker band, which is typically when we're going to start rapid pacing. You see us, what we're doing on the TE, we're flaring out, maintaining a pretty consistent position on the septum. Now I roll the gantry LAO. I roll the gantry LAO to take parallax out of the valve, but I want to prove to myself the concept that I just described earlier. Look at the base of the pigtail and look at the base of the valve and look at that relationship and how it changes as the valve flares out in LAO. As the valve flares out in LAO, basically look at what happens to that relationship. It'll play again in just a moment. So it looks like the valve is rising in relation to the pigtail, right? So again, it's starting with this distance, and as we pace over the left ventricular wire, you're going to notice what looks like the valve moving upwards in relationship to the pigtail, right? That's because this pigtail is not representative of the native annular plane. The valve is actually quite stable in deployment. We knew that because we were watching it with a transesophageal echo. But changing the view like this misrepresents the native annulus. And so that's the reason why you want a view that keeps your native annulus in 2 dimensions and does not put parallax in it. This is where we decided to deploy the valve. It looks like we popped out, but we haven't. We actually have a very nice seal. It's deployed very well below the insertions of all leaflets. Here's another example. Non-right-left equidistant traditional coplanar, LAO27, caudal 7. Here's cusp overlap, non-isolated, right-left overlap, RAO9, caudal 29. REO9 column 29 on a reconstruction. This is our annular plane. If we were able to rotate the gantry, LAO 30 column 15, you can see that we would have 3.6 millimeters of error. We would add it to the depth of deployment. So I don't like deploying valves at like -1 or -2, okay? If you want to go into an LAO view and deploy a valve at -2, that's fine. Go ahead and do it. But I would rather be at cusp overlap and deploy the valve at 2 or 3 and know that I'm deploying the valve at 2 or 3 versus being in this view and thinking that I'm deploying the valve at 2 or 3, but actually deploying the valve at 6 or 8. So here's what I was talking about with marker band parallax. So here's double curved Lunderquist entering in. This is our cusp overlap view. We do a quick injection here and watch what happens to the parallax on the marker band. It just goes right away. And so now we're going to start our implant. Again, marker band around mid-pigtail. The valve is going to eject out in a very controlled fashion, emanating towards the membranous septum with very little interaction with things below the membranous septum. And so we're able to then exit out the valve, again in a controlled fashion, trying to refine our position somewhere about 1 to 2 millimeters below the insertion of the non-coronary cusp. Once we get to that third marker band, right there, and now we're going to take it up to the point of no recapture. And again, the valve position remains very stable. We've got about a 2 millimeter depth of implantation on the non-side. We then rotate LAO. We've caught the left cusp nicely here. This is something where I would not have position 1 push because I'm very happy with my depth on the left. And if position 1 push too much, then I could pop the valve out on the left side. So here's where you go slow and controlled and don't have position 1 do anything except just hold on to the delivery catheter. Here is showing you how aortography can be very misleading. We took parallax out of the valve and shot an aorta. It looks like we're like 15 deep on this aortogram. So a parallax out aortogram will tell you nothing about your implant depth, okay? And so here's our parallax out aortogram, and it looks like we're really deep. And after that, we do transthoracic echo, and you can see where we ended this valve on that cusp overlap view. So the predictability of all of this, I think, is really key in that if we understand this anatomy and we have a self-expanding platform with a stable deployment, it should cause less conduction disturbance than a valve that is foreshortening an unpredictable amount from the left ventricle. So the whole foreshortening of the balloon expandable prosthesis depends on LVOT features, oversight relative to the annular area, leaflet calcification, root angulation, coaxiality, and symmetry. I can do a pretty good Sapien 3 implant. I can get the valve at 90, 10, 80, 20, but I can't tell you that I'm going to exactly get a certain depth. With this, I can tell you what my depth is exactly. I think a single-digit pacemaker rate is absolutely key. And this is our institution. This is when we started the technique. And our pacemaker rate went down to about 4.3% in fiscal year 2018. You take all the people that had pacemakers coming in out of the denominator, that's 4.9% in fiscal year 2018. But we got better at this with some of the modifications that I talked about, starting a little bit higher, ejecting the valve into the ventricle, stuff like that. We got much better. And so for the first 7 months of 2019, 212 TAVRs, 83% evolutes, day and a quarter, average length of stay, 1 pacemaker, just 1. And so a lot of these patients have conduction disturbances coming in. It's not like all of our patients who have right bundles, like our electrophysiologists are putting in pacemakers. That's not happening. And so basically with this technique, we've been able to really reduce our pacemaker rate down significantly. To go over it again, really what we're doing is we're starting higher. And so basically this marker band is not going to negotiate below the middle of the pigtail. And by doing that, again, we're able to eject the valve out in a very controlled fashion, allowing much, if any, contact with the muscular septum. So slow and controlled here. Once we get to the depth that we want and the valve is flared out nicely, we're going to get up to the third marker band and we're going to pace over the left ventricular wire, as you'll see in a moment. We're pacing right here. We get up to the point of no recapture. We shoot a quick angiogram to confirm that we like our depth on the non-coronary cusp. We like that. We're going to rotate now LAO, do a quick shot there. We like that too. And we're going to go ahead and slowly deploy, and then we do an aortogram, which doesn't make much sense at all. So this is kind of, again, showing you how we manipulate the imaging. And so in the middle of the screen here, I'm going to again manipulate this image to go from the traditional coplanar, which is LAO9 caudal 2 in this patient, to a cusp overlap view, which ends up being REO 15 caudal 27. What I'm then going to do is draw this as my annular plane. And again, I want to show you what happens if you would deploy this valve in an LAO 30 caudal 15 angulation. So if we did then go LAO 30 caudal 15, you can see what happens. That yellow dot, almost predictably, it slides below the annular plane as represented on 2D fluoroscopy. And here we're going to add 4 millimeters of error to our depth assessment. This became increasingly important as we considered enrolling patients in the low-risk trial. We've been doing this technique since October of 2015. That's when I got my job at the current place that I'm at. And when I got that job and I came in, I said, you know what, I'd really like to start deploying CoreValve this way. And everyone was all about it because our pacemaker rate was well into the double digits. So we started doing this technique in October of 2015. Lo and behold, we get a phone call from Medtronic in early 2016 because we were a very strong partner with Medtronic in the previous clinical trials, the US Pivotal, the CERTAVI. We were the lead enroller in the world in CERTAVI. And they offered us the Medtronic low-risk trial. Not only did they offer us the Medtronic low-risk trial, they said that, well, you can be the first deployment or the first valve deployed in the Medtronic low-risk trial. So we ran with that. But we were very serious about our outcomes. We wanted very low pacemaker complication rate for TAVR. My surgeons were really adamant that TAVR was going to be non-inferior to surgical aortic valve replacement in this trial. And so, you know, it was set up for surgery to actually have very good outcomes. We were dealing with patients that were truly low risk. They were getting 1-to-1 randomization between TAVR and SAVR. Both of these studies obviously fully enrolled, and the data was presented at ACC and simultaneously published in the New England Journal of Medicine. Instead of rolling through the low-risk trial results, which obviously have been covered in several other venues, I'll just tell you about our personal experience. So we enrolled over 10% of the trial population. We were by far the lead enroller in the clinical trial. This is the randomization that happened between TAVR and SAVR in that clinical trial for us. And here are our single center outcomes. So we had 65 people randomized transcatheter aortic valve replacement, 63 to surgical aortic valve replacement, 6 concomitant stage revascularizations in either group, 1 30-day reoperation, 1 30-day mortality with TAVR, 1 disabling stroke with TAVR, 2 disabling strokes with SAVR. Mean length of stay was less than a day and a half with transcatheter aortic valve replacement, with almost 90% of our patients going home the next day. Surgical AVR also had a very good length of stay. It was just slightly over 4 days. We did not discharge anyone with ancillary services, most often with TAVR and SAVR, and Medicare was the majority payer, as it is in the United States, for transcatheter aortic valve replacement. Our profit margin was better with TAVR than with SAVR. Why is that? It's mainly because of this difference right here, this length of stay difference. And what drove the length of stay difference was this, our 30-day pacemaker rate in the Medtronic low-risk trial. So the 30-day pacemaker rate in the Medtronic low-risk trial for us was 1 out of 65. We actually expected the outcomes of Medtronic low-risk as far as pacemaker rate was concerned, based on our experience, to beat surgery. Like, that was our perception, that it would beat surgery. Because our surgical AVR pacemaker rate was really high. And the reason why it was high is because my surgeon wanted a less invasive procedure for every single patient. Well, less invasive procedure typically means rapid deployment aortic valve. The rapid deployment aortic valve, like Intuity or Percival, those have very high pacemaker rates. And the reason why is because you have basically a sutureless deployment, 3 sutures, and you got this fizzy cuff that basically then gloms onto the LVOT and can shut down conduction. And so that is a pacemaker machine, but this valve clearly is not. And so here is a scatter plot of all of the sites in the low-risk trial, okay? So each dot is representative of a single site's outcome. The pacemaker rate is on the y-axis here, and the number of subjects implanted with transcatheter aortic valve replacement is on the x-axis. This is a standard funnel plot with 2 standard deviations represented by the solid hash lines and the fine dotted line there. If you're a red dot, then that means you're out of the bounds of 2 standard deviations. So something dramatically different is happening, right? That was us. So we were down here. So we had implanted the highest number of patients in the clinical trial, and our pacemaker rate was just 1 out of all those patients. By the way, all of these dots are representative of patients that did not have permanent pacemakers coming in. So when you then adjudicated us for inbound right bundles, obviously inbound permanent pacemakers, inbound left bundles, pre or post dilation, all of these things were not related to the pacemaker rate. So really the technique is really what caused this difference. And obviously I've been able to really embrace this and have my colleagues in Latin America really take this on. So I've been doing a lot of work with several Latin American interventional cardiologists, structural interventionalists over the past year and a half. And in several different educational formats, we've been able to roll this out, and we've had several operators really buy into it. And we have now 1 year of data with many operators across the entire region taking this home and seeing what it did to their pacemaker rate. And with this cohort, we had a post-TAVR pacemaker rate of 4.2%, which is better than any reported core valve pacemaker rate multi-center study. And so obviously Latin American interventional cardiologists are better than everyone else in the world. We know that.
Yeah.
But this is absolutely extraordinary. So we have several research initiatives going on right now. We have an ACC submission on Core Valve XL that I'm doing with my primary data. Core Valve XL is an interesting valve. It has had some negative press because of pacemaker rate related in this, remember the Septum article that was recently released? Our pacemaker rate with Core Valve XL is 5%. We have a prospective multi-center, multinational experience in Latin America called Project Overlap with these 4 distinguished PIs. I'm going to be the study chair on this. We're going to focus on learning curve with relatively low volume centers adopting this technique and seeing what happens with the permanent pacemaker implantation rate. We have a prospective study in the United States called Optimize Pro, where the first 100 implants in that particular study that's ongoing right now are going to mandate the use of cusp overlap when deploying a valve. And then finally, for people that know this double S-curve concept, Nico Piazza and I are actually looking at the interaction between cusp overlap and double S-curve. We think there's about a 93% concordance there between the two planned views. So in conclusion, I think that the optimal gantry angle for TAVR deployment can usually be scripted quite nicely on CTA planning. Keep in mind that the annulus, the delivery catheter, and prosthetic valve are all 3-dimensional structures. When their relationship changes, the 2D fluoroscopy can be quite misleading. You could make a valve look 12 deep, 2 deep, -2. Rotating the gantry in any way, which way, is not going to clarify it in your mind. Parallax out of the valve. At the end, when you shoot your aortogram and you take a parallax out of the, you have no idea what the implant depth is in relationship to that aortogram. TAVR operations and economics do or will heavily rely on avoiding pacemakers out best in class. So with that, I'm happy to answer any questions, but thank you for your attention. Really appreciate it.
Thank you, Hemal. I think that moving forward with the program, we will leave the questions for the end of the session, and we have 2 case examples, and afterwards we will have the questions. Amazing amount of information in just 30 minutes. Bueno, para seguir con la sesión, vamos a tener 2 ejemplos de casos. El primero de ellos lo va a presentar el doctor Alejandro Álvarez Giorgio y el segundo el doctor Matías Speckman. Y a continuación vamos a hacer el panel de la discusión abierta. Me invito a que nos quedemos acá porque vamos a tener un interesante cóctel también.
On the Medtronic staff for the invitation and the possibility to share with you some cases that were done with this amazing technique that till now I named the technique the Gada technique, that I had the opportunity to learn this technique in 2 amazing meetings that were done by Medtronic, one in Miami and the other at the Pinnacle Hospital in Harrisburg. And I had the possibility to stay in the Pinnacle Hospital and see Hemal Gada working, and in that moment I learned this amazing technique that really After I come back to my city in Bahia Blanca, I started to do this technique with gap of overlap, and I improve our result of our TAVR program in Bahia Blanca in terms not only to reduce the necessity of definitive or permanent pacemaker, but reduce the paravalvular leak. This is the first case that is a 78-year-old male patient with cardiac risk factor hypertension, former smoker, obesity. The patient was 145 kilograms. The patient had severe symptomatic aortic valve disease, was symptomatic since 2016 by dyspnea and functional class 2, and this year was hospitalized because cardiac heart failure, acute cardiac heart failure. Data lab show us a moderate renal dysfunction, and echo data show us a peak gradient 70, aortic velocity, and mild mitral regurgitation. This is the ACG that was analyzed by the electrophysiology staff, and they didn't find any predictor of AV block. This is a real low-risk patient. And this is the analysis of pre-op-CT. The patient has had a severe hypertrophy. The angle, the vascular access were good, and we did the measure of the annulus, LVTO, and the sinotubular junction. Then, as you can see in this image, the minimal diameter and maximal diameter was 24 and 30 until 87. Then we decided to treat this patient with an XL device, 34. Then I tried to understand how to get the most important thing is to achieve a very good cusp overlap between the left and the right cusp. Then we did an evaluation of the distribution of the calcium that, as you can see in this video, valve, especially of the leaflets. The objective is to do an implant or a deployment as high as possible. Then we checked the low, and finally, one of the things that I changed after Harrisburg is to be more aggressive with the valvuloplasty and to prepare the scenario for the deployment to avoid an post-dilatation. Then, in this case, I decided to do a valvuloplasty with a 25 millimeters balloon, and this is the implant. First, I put the Gada projection, and then I started the deployment as high as possible. When I came sure about the position, I started a very high rate pacing, 180 beats per minute. And as you can see, the device didn't move any time, only for the orientation. Then I check the date of the deployment in the non-coronary, and I change the projection. And as you can see, seems to be a very high implant, but in this projection, I try to see only the deep implantation of the left side that I was happy. And it took time to finish the deployment in the next cases I show you. I did angio control, that was good. Echo data show us a velocity of 1.6 and peak gradient 11. Didn't show any leak. And this is the AG post-op that we didn't find any changes. As you can see, we compare the pre and post ACG, and the electrocardiograms didn't show any changes. No? The laboratory was good, and this patient was discharged 48 hours without permanent pacemaker. In our 10 first cases, I did CT follow-up, and not only to see the behavior of the device in terms of expansion and position, but to understand the result of this technique and the really deep of the implantation. As you can see in this image, the device is in a very high position without minimal protrusion and minimal touch of the aortic front. Then I understand why this patient didn't need a permanent pacemaker. It's a very pretty amazing images that show us the real depth of the implantation. This is an axial view that we can appreciate the shape of the device, the expansion, the apposition, and the real very low dip and the protrusion of the device at the level of the upper trunk. This is the behavior of the device with the calcium around the device and minimal protrusion. Another image to see the shape of the device and the behavior with the calcium around the device. This is another case of 82-year-old male patient with cardiac factor hypertension, dyslipidemia, diabetes type 2, former smoker, had a severe aortic stenosis, symptomatic by dyspnea and functional class 2. The laboratory was good. Echo data show us a peak rating 68 millimeters, aortic valve velocity 4.1, normal ejection fraction, and the valve was tricuspid. The ECG pre-op didn't show any predictor of AV block. This was a real low risk patient. The angle on the CT was good. The height of the coronary artery were good. The axle were good. We did the measurements, and when we did the measurement of the annulus, we decided to treat this patient with a 34 millimeters balloon. Then I tried to get the Gada projection. Again, the Gada projection in this case was right 27 and caudal 22. This video shows us how to get the Gada projection. That is to achieve a very good cusp overlap between the right and the left coronary cuspid, and in the opposite side the non-coronary cuspid. Another video. We analyze the amount of calcium in the aura and the distribution of the calcium at the level of the valve, especially in the border of the leaflets. This patient had a severe calcification. This is the object of this technique. The coronary angio show a diffuse disease without any significant lesion. Again, we get the Gada projection. We did a valvuloplasty in this case for the XEL device with a 25 millimeters balloon with rapid pacing. After that, we started the deployment as high as possible with the Gada projection. When it was due at a wide position, as you can see in a very high position, I started a very high rapid pacing with 180 beats per minute. Here the position, and I started rapid pacing. As you can see, the device didn't move, only for the dentation. I check the result. I change the position. It took time to finish the deployment. 3 or 4 minutes, because it's crucial to avoid a movement of the device. This is I finished the deployment. I did angio. The result was good. The echo was good. The echo didn't show any leak. And again, the ACG post-op didn't show any changes when I compared with the pre-op. The laboratory was good. This patient was discharged in 48 hours without permanent pacemaker. This is the echo, but most importantly, the CT follow-up that showed us very, very, very small protrusion at the outflow trough, and explain us why the ACG post-op didn't show us any changes. Again, the axial view of the device, but most importantly, this, I think this image, because it reflects the real depth of the implantation. 1 millimeter or less, 1 millimeter in non-coronary caspid. And I think, I don't know, Hemal, what do you think at the left, but it's impossible to achieve the same deep implantation with both thighs, but it's a very shallow implantation that only the way to see is with the CT follow-up. This is my last case, 76-year-old male patient with cardiac factor hypertension, dyslipidemia, a patient with
¿Lo podés sintetizar para dar tiempo a la discusión?
yes. That allowed Joas, data was good. The echo data, Joas a peak gradient 66, the normal ejection fraction. This is the ACC pre-op. Was a very high risk patient. This is the CT and was worried about the bulge of calcium through the aortic tract because the possibility of this is for me a predictor of perivalvular leak and AV block. This is the 3D construction of this case. It's like a knife. The bulge calcium is like a knife, really. And in this image, I saw the severity of calcification of this case and the severity, the distribution of the calcium. Again, the angle was good, the way the height of the coronary were good, the access was good. We did all the measurements. We decided to treat this patient with another 34 millimeters device. We get the Gada projection. This is the objective. This patient has had a diffuse disease without any significant lesion. We checked the load. We did the valvuloplasty. And again, this very patient, 150 kilograms. Then we started the deployment as high as possible. We did a rapid pacing. And we checked the result. We did angio. The echo didn't show any leak. Again, the electrocardiogram didn't show any changes when we compare with the ACG pre-op. And this is the CT follow-up, but most importantly, the behavior of the device with that bulge of calcium at the liver of the aortic tract. This is the last video that shows us the device, the inferior part of the device that is not well expanded because of the bulge of calcium. And I did a 3D reconstruction to see the real deep implantation that was, that as you can see, a small protrusion in the aortic tract. Thank you very much.
Thank you, Alejandro. Great cases, very good images on CT. Thank you.